Hello everyone, hope you all are doing well. So in this session we will discuss upon the market structures related to healthcare and why we don't really have a perfect market condition in terms of the healthcare market, and under which circumstances we move. Generally these circumstances prevail and we move towards the market imperfection. So what should be the ideal condition, market condition in terms of healthcare market? So these ideal market conditions, if we think of in terms of a healthcare market, then there will be 5 to 6 points which directly comes to our mind. So the first point should be, so if ideal market conditions, we are talking about the healthcare market only, so it should be the marketability of all goods and services. I'll change the color. All goods and services. This means whatever is being produced or whatever is being supplied, they should be marketable. So the the quality, in terms of the quality, in terms of the accessibility, it should be marketable. And every single individual who are supplying or who are providing the healthcare services, they should also be accessible and providing the same care, quality of care to everybody. So otherwise, if they are not, say some particular product is so outdated, so it's not marketable, so it's not a perfect condition. And then the second one is that a particular doctor is so poor in terms of his treatment or her treatment that nobody prefer to go to him, so they have a very bad reputation in terms of a doctor, in terms of a clinic, in terms of a hospital. So the marketability is of all the products or the services are not generally ensured. So this is not an ideal market. So in an ideal market, every single healthcare provider or healthcare product supplier or healthcare product should be marketable. Number two is demand certainty. There should be a regular demand which is predictable. That means the healthcare providers have clear idea that what is the number of patients, their patient footfall in a hospital or to a doctor, what kind of diseases are happening or prevalence of any particular disease. They really don't consider if there is a certain weather calamity, some tsunami or some major accident. So or even if that the proportion of affected people is not really very large, so that the demand changes in a massive way, so the markets don't function really accordingly and at their best of their level. In that way, in a perfectly ideal market condition, the healthcare providers should have a clear idea about the demand from the or for the health services from the patients or from their potential customers. The third is supply certainty. Customers or the patients have clear idea about the medicines, about the vaccinations, about the doctors availability, different kinds of doctors availability, about the the diagnostic facilities around, about the insurance schemes, the coverages of insurance schemes, and they know that when I require that, all these facilities are around me, I can avail them. So there is the supply certainty. So when we are talking about supply, it's not essentially be the number, because we in the first point we have talked about marketability of all goods and services. So even if the supply is there and then the quality is compromised, in that way the supply certainty is also being compromised, because even if the supply is there, being the product or the service of poor quality, nobody is interested to go, so they have lost its marketability. So the supply certainty not only talks about the quantity, it also talks about the quality of the services available for that particular population. The next is avoidable risks. Yes, this avoidable risk means that whether people, both the suppliers as well as the consumers, know that how I can avoid the risk, or how I can get away from a particular disease, or from a particular healthcare adversity or health adversity. So this is from the consumer's point. From the supplier's point, they also should know that how, in terms of the services, how the service failures can be avoided, so that if the service failure can be avoided, then this quality is being ensured. The quantity in terms of the demand is being ensured, that they know that if my reputation is not being hampered by a certain casual mistake, then probably I will certainly get I have a clear idea about my demand, so the demand really doesn't vary much. Yeah, they have retained their market. So, or they have been improving, so they know that I will be improving. So it's like that. So avoidable risk can be avoidable. So the people have the knowledge, have the idea about the operations, have the knowledge about the markets from both the demand and supply perspectives, have the idea about the future. So so they know that what will be the best optimal decisions to avoid these kinds of risk, which actually lead to an uncertain demand and supply, and then inefficient production and inefficient consumption. And there is no such problems in terms of that moral hazard or an adverse selection, after avoidable risks, because when we talk about avoidable risks, we talked about the quality idea, about the quantity. So here we will, so in a perfectly competitive market, when we talk about an ideal market condition, we will, that perfectly competitive market gives us an efficient output, right? So to attain that efficient output, because when we talked about 6 building blocks, universal health coverage, we talked about quality a lot. So it's all about accessibility, affordability and quality, right? So and people should have understanding about the quality, about the services they are being provided, right? So when we talk about the services, so it's like customers' ability or the consumer's ability to test the product before consumption. Yes, and it also leads to avoid the risk, because once they are into the system, they cannot. So the customer's ability to test the product before consumption, even if they don't have an idea. I go to a sweet shop, they can say that, okay, you can taste the sweet, and then you can take. So just taste one sweet, a supplement, or you want to go to get some namkeen, get some achar, so they will always, offer you one chamach of this. Yeah, because you don't have probably the clear idea, and you have the ability to taste the product before you consume, before you buy, because healthcare is often an irreversible one, right? Or if I have made a wrong choice, I have made a wrong decision, and if the treatment is wrong, it has a negative impact. So my health stock may go down, my health cost, status may go down further. Yeah, so that's really not nice. So the number 6 is information symmetry. So everybody has a perfect information. Everybody, both the supplier as well as the consumer, have the the consumers often do not have any idea about what the suppliers are providing, what the healthcare providers, because the doctors are God, and then whatever the doctors say, we follow that, right? And we really don't know that what is the motive behind that, and if there is a uncanny profit motive, right, business motive behind the decisions they are making, and we are the guinea pigs. We really don't have any idea. And secondly, the doctors should also know that what the information the consumers, the patients are providing to them, they are right. It can be the doctor, it can eventually be the insurance. If you remember, in insurance, the adverse selection, right? So when the insurance companies want to go for the cherry picking, yes, they want the healthy ones, and then somebody tells, I have always been healthy, I have followed all healthy habits. So they make an adverse selection. And even if there is no adverse selection by the cherry picking, there is a death spiral, right? So this information asymmetry is not really an ideal market condition. So in an ideal market condition, I have information about the hospitals, about the diagnostic center, about the medicines, about the doctors, so that I make my best choices. When I make my choices, that is based on my demand, is based on my utility. Right? My diminishing marginal utility determines my demand curve. So my utility, my satisfaction will be best derived when I have my information. Similarly, the doctors, when they have idea, or the hospitals, when they have idea, or when they know that the consumers, or when the insurance companies know the consumers or the customers are providing them the best or correct information, then their decision making, their treatment process, their policy sales are on an efficient way. So there is no wastage, So that is another information symmetry, is another condition towards the market efficiency. The next one can be no price discrimination. That means all the consumers are being charged the same price, no price discrimination. Yes, all the consumers are paying whatever the rich is paying, the poor is paying the same. What the particular, what you are paying in a for a particular hospital, you are paying the same in another hospital. So there is no price discrimination basically for the same product. Yes, and if there is no price discrimination, because often we don't have idea, because in a perfectly competitive market, there is no product differentiation. If there is no product differentiation, logically there cannot be differential price, right? And when there is no, again, market fragmentation, no segmentation of the market, so there is no point that why there should be a price discrimination. If there is no societal objective behind this price discrimination, that I will keep the price lower for a certain population. But that's also not right, because whenever we are in an ideal market, in a perfectly competitive market mostly, then there is no profit, no loss context. And if a person is producing or supplying in a lower price, there can be two issues. One, they are making losses. Yes, and then the other, even if they can draw all the customers towards them, the others will also lower the price. Again, that will be distributed, and everybody make losses, so the price will again go up. Number one. Number two, then there can be one condition, because as there is no product differentiation, the lowering the price may make a sense that the quality of the product is degraded. Right, that will send a message like that. Otherwise, nobody giving the same product, or same quality product, will really not be able to decrease the price and sustain in the market. Yes, so eventually there is no price discrimination possible or allowed. The eighth one, or the last one, that all the suppliers in a market have a profit motive, a very important one, that if they have a profit motive, how they can earn it can be an ideal market, right? Because if there is a profit motive, everybody would like to be a price taker, price setter, not a price taker. Everybody would like to differentiate based on their product. Now, a very important aspect in terms of healthcare. When we talk about why they all want to be a profit, they will have a profit motive. First thing is that The healthcare market, in most of the cases, if not Cuba or something like that, most of the cases it's a mix of public and private. If it's a mix of public or private, even if there is private clinic, they may be paid by the insurance or some government agencies, or by the government. The private clinics or the doctors are their price setters, and everybody will have a, they are rational by nature, so they have a profit motive. So this starts with the economic concept of rationality. So they are rational, so they have a profit motive. Right now, healthcare market is fragmented. It is very, very heterogeneous, and the product differs from places to places, population to population. The services differ from places to places, to population to population, and therefore, and often we have found it's not very easy to quantify a healthcare product. So often we have found the service or the goods or the commodity, healthcare commodity, if we can consider as a single good or single service, they still are different in terms of quality. Yes, and if there is a there is a differential, even they may not be a perfect substitute. They can be little close substitute, like we have seen in monopolistic competition. They can be close substitute, but then there is little chance, even if little chance, for these providers to set their own price. Yes, eventually in the long run we have seen that it can come down. The demand curve finally becomes tangential to average cost curve, where the price and then the cost, average cost and then the price are at the similar point, right? So there is no profit basically in the long run, but in the short run they have a profit motive. Right, so it works like this. It's a very rational market. So there is nothing wrong if they have a profit motive, but there have to be an intervention. Who intervenes? The government or the health insurance companies or somebody. So there has to be an intervention. So now, understanding this, marketable, ideal market conditions in terms of a healthcare market, we will try to understand that under which circumstances they move towards imperfection. So perfect competition to imperfection. The first one, as we have learnt here, is the marketability. So here also we will talk about the product marketability. And what is product marketability? We already talked about that all the products are not of the best of the quality, the accessibility is not good, the price has been too high. So, there are several conditions under which the healthcare products are always not marketable, and there has remained a question in terms of that whether there is an excess supply or not. If there is an excess supply, then the price may be high and there is a surplus. Right, and then in that price, there is a shorter demand, lesser demand, so there is a surplus, so which will finally bring down the price. And if there is a the product is not really marketable, or there is a large number of product, goods and services which is not properly marketable or marketed, then the the price, the market is not in an equilibrium or is not intending to produce an efficient outcome. Yeah. So the second one, just after this comes information asymmetry. In terms of information asymmetry, again what we learned, that information asymmetry from both the sides, supply as well as demand, the consumers as well as the doctors. So there should be information asymmetry in terms of information. What happens if there is an information asymmetry? Then there is always a possibility, because the healthcare providers have the information, they generally have an advantage over the consumers. Yes, and then they can lie to us, and then they can fool us with extending some unnecessarily services which is not required at all. So, and because we don't have idea and we trust them because our life, our health is at stake, so there is always a chance that again the production is being produced at an inefficient way, of course, or an inefficient output, quantity of output, where the price is high, and then the consumers are not actually getting the cost effective output services or the health. So they are paying more than what they are actually getting. So and that primarily arises because the consumers do not have enough information to make their best of the decisions, or to choose that whether to get a service or not to get a service. Similarly, the doctors don't know that, or the health insurance insurers don't know exactly at which point, say the health insurers don't know exactly at which point the price of the policy, the premium has to be set, because if the patient is lying that they are not unhealthy, that means the price is being set at a high level. The price is being set at a high level, low level, what should be than what it should be, because the probability of sickness of that person is being judged by their health profile, which is wrong in this case, and then the probability of sickness estimated is low, and hence the the expected payout for that particular person is low, and then the premium for that particular person has been estimated low. And now when that person falls sick, because of this concealing the information, so what happens, that the person is actually falling sick and expecting a higher claim as compared to what the health insurance has estimated or expected or kept for them. So the net amount at risk, so the chance of making loss has increased for that health insurance company. Again, that that puts them in a condition where to make that loss up, they will try to find further healthy customers and will ignore the unhealthy poor customers, and then it is falling back to the from adverse selection to another adverse selection towards cherry picking, and by that they are causing a death spiral. And this is not ideal, because those who are finally, what is happening because of this information asymmetry, those who require insurance, because of some people they are not getting the insurance. The third one, in terms of the doctors, if they don't get the information properly, they fail to give the best treatment. If they fail to get the best treatment, because they give the treatment based on the information they have got, if the information is is not proper, then the treatment process probably is not at its best, and if the treatment process is not at its best, the health outcome is not again the most efficient one. Therefore, the price maybe they are paying, the consultancy charge they are paying to the doctor has remained the same. Yes, has remained the same, but what is happening, the outcome is differing. Now the outcome is low, so there is again a wastage. This is known as deadweight loss, what we will learn more in when we are discussing about externality. The third one is adverse selection. As I said, that if again it comes from the information asymmetry that we have already discussed, because of this information asymmetry the adverse selection appears. Adverse selection leads to this cherry picking and market failure for the health insurance companies, and then the health insurance companies become very choosy. So adverse selection is not the best way, and then the underwriters actually face a huge difficulty because of this adverse selection. They don't really know that what should be the price, because the actual scientists just estimate the probability for the health insurance company based on the information they have got, and then they don't know that whether the information is right or not. And because based on that probability estimation the underwriters set a premium, and because of that estimation is wrong, so the premium is estimated wrongly. Yes, so the fourth point is moral hazard, where we find those who have insurance, they have a higher tendency, those who have insurance, they have a higher tendency to seek medical care, and which are often unnecessary. Um, just like that, we have learned about moral hazard, but I will still, if you have missed that session, so I will still like to reiterate that moral hazard is when I have insurance and then I go to the doctor to trim my nail, you know, or just for a toothache, you know, and if maybe it is nothing, but then I still go to the doctor, and then, you know, for some unnecessary services as simple as, you know, trimming my nail. So nobody goes to the doctor to trim their nail, but it is covered under my insurance, you know, and then the doctor probably could provide that time to a person who really required some serious treatment, and then that, because again it's a kind of common resources, or even if it's not a common resources, even if it's a private good, there is a rivalry in consumption. And if I am going for some stupid reason to see the doctor because I have got insurance, I am actually, you know, denying somebody's chance to meet the doctor, and then you know, the outcome per unit time from that doctor, yes, is actually, or the hours of labor the doctor is providing, right, that's my labor. So the average productivity of the labor is actually going down, because my output is way lesser than if he could give somebody who really some input, consultancy, treatment, who really want it seriously. So this moral hazard, you know, it leads to again the insurance companies to take a back seat, because what happens, and then they are very careful while giving the insurance, and often go extremely desperate to get the healthier patients to make the profit, because of this moral hazard they lose a lot of money. And it often happens that even if I don't require a hospitalization because I have health insurance, just for a, say I have just twisted my hand and a plaster or some bandage will help me, but just to get that I will get an hospital admission, because if I get an hospital admission, then probably I will get the insurance. And if I get the insurance, now say if I have got my plaster, to get the plaster it charges me around 15,000 rupees, sorry 2,000 rupees, and or say 5,000 rupees in a day. But if I am going opting for a hospitalization, then probably it is 15,000 rupees, and my co-payment is maybe 10%, 90% comes from the insurance company. So how much I am paying basically out of 15,000 rupees? 1,500 rupees, right? So anything more than 1,500 rupees, that difference is my savings. Yeah, so if it was 5,000 rupees and I could come back home, now I am paying 1,500 rupees, so I am saving 3,500 rupees. If the the hospital, they were getting 5,000 rupees. Now if they have a free bed, now they could make that bed occupied, now they earn 10,000 rupees more, from 5,000 to 15,000. What is the loss of the insurance company? They didn't actually have to pay anything, because it doesn't really make sense to ask for an insurance, right? So from zero, now they are paying 90% of 15,000 rupees, that is 13,500 rupees. So that is the loss they are making. And to make this loss, to make this to manage this particular loss, to make this up, so they will go for a healthier patient. I mean healthier, not a patient, healthier individual. Yes. So and then the fifth one, I will go to our next page. Fifth one is interdependent demand and supply determination. Yes. So what happens is, with a higher demand, We know that when the demand is high, there is a tendency that the price may go up, and what happens, an increase in demand because of say some flu or some uh, major viral issues in a particular locality. The doctor says that there is a higher demand, and then the customer base has really increased. So what happens, that the doctor initially maybe they want to earn 5,000 rupees a day, and he could earn by seeing maybe 25 doctors, charging 200 rupees from them. Now as he can see that there is a higher demand, so they decide that, oh fine, okay, I will not to just to earn my, their profit is not the by the number, their target is not the number of patients they are seeing, the target is 5,000 rupees. So if they want to earn this 5,000 rupees, and now there is a demand, right, they will get 25 people very easily. So what they will do, they will now see that say 20 people charging 250 rupees, or even 17 people charging 300 rupees. So that makes, and we know in a short run the price elasticity of demand for healthcare, if it is not basically self-induced, or if it is during the emergency, during the disease period, it is very, the price elasticity of demand is very inelastic. With the increase in price, the quantity demanded doesn't really fall. Therefore, and when it is inelastic, what happens? The total revenue by the supplier increases during that inelasticity, right? So similarly, during this inelastic period, when there is a major rise in demand and then the price increases, which doesn't really have an impact on the demand, so the doctor can actually limit their number of hours of services. Yes, eventually what is happening, by limiting this number of hours of services, we actually see a backward bending labor supply curve. We see a backward bending labor supply curve. Yeah, so these are very this interdependent demand and supply determination. Then based on demand, the supply will be determined, or based on supply, the demand is determined. But it's not really so prominent that based on supply, the demand will be determined, because healthcare scenario is, I don't really want to see a doctor if I am not ill. The health seeking behavior is mostly like that, yeah, mostly. So the based on supply, the demand is, yeah, of course in terms of quality they can choose if there is a and we know that the product marketability has been questioned under when we move towards this imperfection, and based on this product marketability, my interdependence between demand and supply can vary. Right. So the sixth is consumers' rationality and ability to make the best judgment about their welfare. Yes, what does this mean? Does this mean that consumers' rationality and ability to make the best judgments about their welfare is, they have, the consumers should have a perfect knowledge what they don't. So the consumers' rationality and ability is questioned. Yes, they don't have an idea about, they know the preference, but they know the budget constraint. So they know that based on that preference and budget constraint, what is their highest, based on their indifference curve and then the budget constraint, that this much of health and this much of leisure I can avail, or this much of health and this much of, doctor, this much of medicine I can avail, and something like that. But at the same time, while they are taking their judgments, they are often not very clear about how the welfare is being ensured, how their health, best health is being ensured, whether it is really being ensured or not. They have taken the decision to choose their doctor, choose the hospital, but they don't know whether the doctor or the hospital is the best ones for their particular case. So this has remained a question, So the consumer's rationality and ability, even if it's there, or the rationality is there, but the ability to make the best judgments about their welfare is often not there. And in terms of rationality, when the persons do not have enough education, they are not very rational to take their decisions. Yes, they don't have much knowledge, so they are not very rational to take their decisions. Or eventually, maybe the accessibility and affordability is not there. So they are rational now, but the rationality leads them not to choose for healthcare. Right? So this rationality, because they cannot, even if there is no accessibility and affordability, they cannot ensure that okay, fine, let me get the treatment because it's not far away or it's not expensive either. So they choose not to get the treatment because that's a rational decision. They cannot spend 3 days or they cannot travel 100 kilometers, right? Or so that rational decision lead them, and that's not the most efficient healthcare production. And of course, if they don't have awareness, they don't have knowledge, so the decision is never rational because they don't know the importance of the health, or they don't realize, or they don't know importance of a particular disease, that how far it can lead to, or importance of say health hygiene practices, the sanitation, the immunization, right? So the seventh one can be, in terms of this, the consumer's rationality and the ability to make the best judgments, there are two things which mostly the suppliers look at, because the suppliers always will try to get an idea about the consumer's pattern, demand pattern, to have a better predictability of the demand condition. So the two things that they try to judge is the consistency and transitivity. Consistency is how consistent the patients are, or how consistent the decision makers, the consumers are, while they face the same condition again and again, whether they are making their demand at the same consistent pattern or not. In terms of transitivity, it's a mathematical condition. In transitivity, we try to see that, it's that if A is preferred over B and B is preferred over C, A is also preferred over C. So transitivity means this condition prevails. Right? If I prefer allopathy over homeopathy and homeopathy over Ayurvedic, so I will prefer allopathic over Ayurvedic. But we often don't see this clear distinction while it comes to the choice making in terms of the healthcare behavior, because our healthcare demand in a developing country with lesser education, lesser awareness, is often not this rational to follow this transitivity. And we have seen that often this healthcare they behaves very differently in these setups. There is a networking effect, there is a bandwagon effect, there can be a given goods condition, so, and where the demand predictability or the consistency, both the sensitivity and consistency are compromised, and the rationality or the patients or the consumers or the healthcare seekers decisions towards their welfare are not basically the most rational and efficient one. The seventh one is predetermined customers' tastes. This predetermined customer tests is they have an idea, or they know that I will go to this homeopathic doctor only. I will go to this particular hospital only. I will take this particular medicine only. It can come from a brand loyalty. It can come from a tradition. You know, in many cases, in many countries, in many societies, we have seen that they have a family doctor, and the families, if there are 2, 3, 4 doctors, then it can happen that it is, the every family has different doctors, right? So this is like predetermined customer tastes, and maybe while I went to a particular doctor and then my fever was not actually coming down under that doctor's treatment, and I went to another doctor and then his medicine reduced my fever. That may be that even if I would have continued with the previous doctor, my fever would have come down on that 4th day, but on that 4th day or the 5th day I went to that other doctor. So the nature of the fever was actually mistaken under this, the doctor's preference. So it is like, and then that makes my choice that the first doctor maybe was not the best doctor, right? So the predetermined customer tastes often lead to a market failure, and that is where the allocation of the products or the services are not at its best, because if in a particular locality people prefer to go to allopathic doctors, or say homeopathic doctors, or say even a quack, even if there is a qualified doctor maybe 5 kilometers away, so they don't, or say 10 kilometers away, they don't go to that qualified doctor, they go to a quack who sits in that village only, because that is the predetermined choice, right? And then the efficiency is actually compromised. And here in the first case maybe the consistency is not there, and in the second case what happens, the transitivity is not there. So the predetermined customer test is a very important point to lead to the market imperfection. And then 8th is the profit motive. It also raises a question whether health is a right or a profit-oriented private good. If it's a right, like what we see if in case of what universal health coverage says, what World Health Organization says, what Cuba says, that is right. And everybody should have equal amount of most efficient health status or healthcare services, everybody equally, yeah, and of the efficient one. But what happens is, if it is often, of course, in most of the countries it is difficult to ensure that the government will provide health for everybody. So who fills the gap? The private organizations. The private organizations will not work on the same line how the government philosophies work or right-based approach works. Because they are private, they don't bother about anybody, they just want their business, they just want to make money, right? The government gets their money out of the tax and whatever, but private, so it's their business, it's their bread and butter, so they have to earn a profit, right? They cannot operate in a normal profit, literally, so and they have families, they have their own demands, choices and preferences. So naturally there will be a profit motive, and if there is a profit motive, then the market fails, that it is in terms of from the ideal situation. Yeah, so the hospital will have a profit motive, the private clinics will have a profit motive, the diagnostic center will have a profit motive, but then how far it is entertained, that the government needs to take a decision. So it should not be extremely high that it discriminates among people, and they cannot keep it very low. So it should be justifiable, that the level of profit they intend to earn. And say, just for an example, how this profit motive leads to a fragmented market or leads to a price discrimination. I stay in Bangalore. A particular immunization for a child in Bangalore, say it charges 4,000 rupees. I go to in a private nursing home or hospital. I go to a government hospital, it charges 2,000 rupees. I go to a government hospital in Hosur, or not a government hospital, may it be a semi-government hospital or something like that, a charitable organization. I go to Hosur, you know, which is just half an hour away from Bangalore, maybe in Tamil Nadu, or I go to say Mysore or nearby Ramanagar or somewhere, yeah, which is small towns around Bangalore, that eventually comes down say 1,500 or something like that. So you can see the profit motive, the difference in the price, and that is a market differentiation, and that's really not nice. Right, that is an uncanny business, but government has to regulate. We don't know, we cannot go to a government hospital, you know, stand in a queue for 2 hours to get the price. So if we can afford, we prefer this. And then there is a snob effect as well, you know. So we go to that private hospital, 5 minutes business, just get the immunization, come back, and we don't bother that whether you know, it's 5,000 rupees or 3,000 rupees. So I just can't stand for 2 hours 2,000 rupees, because otherwise I have to take a leave on that particular day. Probably my opportunity cost is higher than what I save, you know, by that 2,000 rupees. The next one is externalities. It can be both positive externality and negative externality. Now this positive externality can appear from production as well as from consumption. Similarly, my negative externality can appear from my production as well as my consumption. So the production externality means, and what is you know, the positive externality and negative externality? They are particularly that when, what is externality? This is the difference in terms of the social benefit over costs and social cost over benefits. You know, so if my in terms of positive externality, my social benefit should be greater than the cost, whereas for negative externality, my social benefit or my benefit, mostly private benefit. So when positive externality, we talk about social benefit and private cost mostly, yeah, not essentially. Here private benefit is less than the social cost. Yes, here again mostly private benefit. Now here also we can talk about social benefit is less than social cost, but now what is social benefit? Social benefit is basically, or social cost is basically private benefit or cost plus external benefit or cost. You know, if my private benefit has, or my production has, if I produce something I have a benefit, or if I consume something I have a benefit, and if because of my production and consumption some other people who are not directly paying for that or producing or consuming that, you know, they also have a benefit because I am producing something or I am consuming something because of my production, because of my consumption. If they are having a benefit, then that is external benefit, and together that is social benefit. And if the social benefit is more than my private cost, that is a positive externality. Similarly, if I produce or consume something, I pay a cost, I gain my benefit, but because of my production and consumption, somebody else is having a cost. It can be a pollution, smoking cigarette, anything. They are also bearing a cost. That is their external cost, right? They are not getting any benefit. That is their external cost because of passive smoking. So this together is social cost, right? And this social cost may be more than my private benefit. Then there is a negative externality. We'll discuss about this more in the the next session. But the last point, which leads to the market imperfection from the out of the ideal market condition, that is returns to scale. Which color? Okay. Returns to scale, point number 10. Yeah. And this returns to scale is basically, they talk about increasing returns to scale. If you remember what is increasing returns to scale, that is my output increases more than the, or my rate of increase in my output is more than the rate of increase of my input, right? If I increase my capital and labor by twice and I get more than that, I get say from 100 to 200, 100 to 200, my capital and labor increases, but my output increases say from 1000 to 4000. That I increase my capital and labor twice and twice, but my production increases by 4 times or anything more than 2 times. So that is my increasing returns to scale. What happens during increasing return to scale? Again, if you remember, we are on the downward slope of the average cost curve, right? Here we basically see the increasing return to scale. Here it is decreasing return, constant return, right? So in increasing return to scale, what happens? Our average cost is lower, right? Or it eventually goes down and down. So with this average cost, when we have this lower average cost, there basically we found our the fixed cost is high, or the share of fixed cost in total cost is high. And with the production, if you remember again, with the production, the average fixed cost comes down, right? Because it is total fixed cost, which is a straight line, divided by the quantity. Yes, and if it is coming down, right, that means if this share, this particular share is high, or this particular share is high, that means when I produce, like at the initial period, I have probably to set up a hospital, I have to get a lot of equipments, lot of beds, diagnostic equipments, certification charges, a big hospital building, ambulances, a lot of human resources. So the fixed cost, initial investment for this building, capital and all this is very, very high. Once it starts operating with the quantity of the production, the patients being treated and all this, once it starts operating, that fixed cost gradually goes down, and the more is the patient, more the down, it goes down and down. So what we find when we have this total fixed cost more, that means a capital intensive system, which we can compare between a big hospital as compared to a smaller hospital. That means that big hospitals are technologically sound, have more capability to serve more number of patients, are more holistic in nature, can accommodate best doctors or complicated services. That means they are having an edge over others in that market, right? So they have they can slowly gain the market share, because with the more and more customers, their average cost is going down, and once their average cost is going down, their profit margin is increasing, right? once their profit margin is increasing after their break-even point, they are slowly moving towards, from the break-even point, they are moving towards that positive total revenue, total cost period where the total revenue, total cost is more. If they can attain that and they can strategize in a better way so that they can perform in that indifference return scale, this lower section of their average cost curve, or can work out a better revenue strategy, what happens? They can rule over the market, and slowly with this, with increasing return to scale, or say the lower average cost, they will not only survive with the profit, but they will eventually be a price taker, because with that profit they can invest more. With the investment they can eventually get more uniqueness towards their system. They can pay towards more advertisement. So from perfect competition, they are moving towards monopolistic competition, more advertisement, more product heterogeneity, and then they are moving towards more oligopolistic market. And if they can, because in that way they are being larger and larger, and then their market share is increasing as compared to the smaller ones, because the smaller ones didn't actually invest much. Their average cost after a certain while starts going up, because with more patients, when their average cost starts, they may have a smaller average cost curve, and further more smaller average cost curve. So with after a certain very small number of patients, their average cost goes down, so they cannot really accommodate a large number of patients, and then they actually trickle down to this, and where they can accommodate still a very large number of patients, these big firms, and this gives them an oligopolistic nature in the market. Slowly they can form a duopoly and a monopoly eventually. So this increasing return to scale leads to a market imperfection, where they can move to a perfect monopoly or natural monopoly, and with this price discrimination they can they can do a product differentiation, they can do a price discrimination at all. But what the government can do, that this market imperfection is really not the desired one. So so to reduce the effect, but we know that it is nearly impossible, everybody cannot be Cuba, that it is nearly impossible that they can reduce the market imperfection, or everything can be government controlled, where Cuba doing that is providing the best of the services as compared to the many developed countries. But the government can ensure the equity and efficiency based on taxes, based on subsidies, the best distribution and allocation of funds, increasing the accessibility, providing several schemes, health insurances, towards the underprivileged ones. So the the distribution is more, affordability is there. So they have to distinguish between how far the profit motive can be entertained, and till how much I can sustain with my human rights concept of healthcare provision. And looking at the social benefit and social cause, they have to identify that whether it is a public good and how much benefits can be provided, and if it cannot be a private good because of the tragedy of commons or free rider, they can move slowly towards the private good and maybe work out a public private policy or a corporate social responsibility. And like Grossman says, that everybody has a health stock which goes down depreciation through the depreciation, but they can improve that. They can improve that with better education, occupation. What the government has to ensure that the better education, occupation, along with the health, all the tentacles and awareness and everything. So so that is where the government has to bring a strong philosophical foundation of the healthcare system. If their philosophical foundation is strong, they know that what is there, we have a lower market imperfection in terms of healthcare. Thank you very much.